Recording in
spaces,
progress.
they are also appearing relatively normal. And the alignment, I'm trying to see, there's no history of trauma, but alignment was also appearing relatively normal. I can see a bipartite medial sesamoid, which is there at the base of first metatarsal. So, considering, I would like to know the age of the patient,
60
because
years
given
old.
these findings, 60.
60 years old.
So,
Okay, so here's a
cut-
tip. Okay, stop.
yes, sir.
Here's a tip. Okay. You've asked a question. Let me answer the question. Okay. This is for all those candidates who are sitting the exam. Okay. You asked me a question. I would like to know the age of the patient. And even before I've answered it, you started talking again. Once you ask a question, look at the examiner. The examiner may either give you the age of the patient, give you the information that they are going to give you, or they may turn around and say, which I sometimes say, sorry, that has to be earned, not given. Okay. So if you ask a question, slow down. Okay. Stop, wait for the answer. If you're not getting the answer, they will either politely decline or they'll give you the answer if they think it's relevant or it'll help the case. Okay. Go on. Tell me what you think.
Sure, sir. So, given the age of the patient, which is 60 years old, I would like to think in terms of degenerative arthritis,
Okay.
predominant, yes, predominantly involving the midfoot because of the sclerosis, subchondral cystic changes, which is very evident along the intertarsal joints, predominantly along the navicular as well as the medial cuneiform.
Okay. Does this change your opinion? Yes or no? It may or may not.
I'm just taking a moment to have a look at the images, sir.
Mhm.
So, and mm, I do not find anything additional to the. Actually, now I can see that, yeah, the joint space, whichever was appearing reduced, is similar, but I'm not able to clearly appreciate the subchondral cystic changes, which I was mentioning previously in this. But the other visualized bones are also appearing grossly normal.
Okay.
So,
So what
I-
is the pathophysiology of osteoarthritis? What are the okay, forget
pathophysiology.
that. What are the hallmarks of osteoarthritis on imaging, on X-rays?
On X-rays, sir, for osteoarthritis, predominantly, initially, there will be first a reduction of the joint space will be there. Where
Mm-hmm.
in the early stages, there might be a mild joint reduction, some amount of marginal osteophytes, some sclerosis along the articular margins, some subcortical cystic changes, that is because of the degeneration of articular cartilage along the joint surfaces, there can be some subchondral cystic changes, and in the
Okay.
chronic stages there can be complete loss of joint space.
Okay. All right. Okay. And what is the typical distribution of osteoarthritis
It is
in hand and
the
feet?
no, osteoarthritis typically occurs at the areas of pressure, sir, where there is more weight bearing or more pressure related areas. So,
Well, hand is not a
in the foot,
weight-bearing area, is it?
no, 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 no.
Okay, so
Yeah,
that's
it is
not the
not.
way I would put it, right? Hand, I don't stand on my hand, so it's not a weight-bearing joint. What is the typical distribution?
Mm, me, along the medial joint spaces,
Okay, don't worry,
typically.
don't worry. We will come back to
Mm,
this. Do not worry about it. We will come back.
okay,
There's okay. Don't. This is just a teaching session. This is just a teaching Viva. Okay. So
sure, sure.
we have. Okay, all right. Hold on. Let me bring up all the images. Okay, so there's one here, and there is one there. Okay, tell me what you think.
Yeah, I'm presented. Firstly, I'll be talking about the X-ray of the pelvis with bilateral hip joints, radiograph of the pelvis with bilateral hip joints, and in the given radiograph, I can see I am trying to visualize all the bones, the sacroiliac joints, and the visualized vertebrae. And initially, I can see that the major abnormality is along the the left femur, that is the proximal metaphysis of the left femur, where there is a fracture, displaced fracture involving the proximal metaphysis of the left femur. And I'm just trying to have a look at the other bones if there are any other associated pathologies. I can see that age-related changes, that is degenerative changes, are noted in both the hip joints as well as both sacroiliac joints, predominantly on the right side. I am trying to look, since there is a fracture which is present on the femur, I'm trying to rule out if any other acute pathology is seen in the other bones. However, I cannot see any obvious displaced fracture in this radiograph. I'm unable to clearly visualize the sacrum, the lower end of the sacrum and coccyx. I think that is
Sacrum and
because of
coccyx are fine. They're fine.
oh,
Tell me what you think of the fracture. There's no other findings. Don't worry about osteoarthritis and everything. What do you think of the fracture?
Sir, because there is presence of a generalized mild decrease in bone density, because I can see the trabeculae prominently. I'm thinking it in terms of fracture because of decrease in the bone density. So that is
I think the
uh,
bone density is pretty decent for a 77-year-old female.
okay. Um, okay. So, okay, then the other thing is I would like to, in the proximal fracture fragment, which is visualized, that is on the lateral view of the radiograph, which is provided, I can see that some ill-defined lucency is noted along the
There's no
proximal
underlying bone
fracture
lesion.
bone
No
lesions.
underlying
Okay.
bone lesion.
And I can see that there are few calcific foci which is seen in the left iliac fossa, sir. So considering it to be
Ignore them.
um
Completely ignore them.
okay.
I want you to just
Um,
talk about the fracture. Tell me what you think.
since it is a normal
Okay.
density, there is no other bony lesion, and there is a
Okay.
fracture with the distal fragment displaced medially. Um,
Okay.
I'm
All right. I tell you what happened. So the
okay.
clinician looked at the X-ray. This was an A&E. She came in. The clinician looked at the X-ray and then decided to X-ray her right femur as well. Ignore that. That's her right femur.
Yes. So, so in the provided X-ray of the right femur, I can see that the cortex is appearing thickened, sir. The cortex is appearing significantly thickened, diffusely, um, slightly more prominent in the distal aspect along the lateral cortex, but I can see that there is a diffuse cortical thickening which is there along the entire aspect of femur. So, if considering it to be a case of in this patient, it can be a case of hypertrophic um, primary osteoarthropathy. I would
Okay.
like to, sir,
All right. Okay.
uh,
I think
I
we're
would
going
like
to,
to
yeah, go on. Go on. Finish the case.
I would like to delineate the causes for this condition. Like primarily, it is because of the lung condition, like bronchogenic carcinoma or chronic lung diseases, or it can be because of heart diseases or chronic in extrapulmonary causes, or it can be because of chronic long-standing diseases in the abdomen, like IBD or cirrhosis. So, I would like to know the previous history of the patient, which has led to this,
Okay.
and I would like to
Okay.
inform the findings. Yes.
Okay. All right. We're going to stop there. Okay.
Okay.
We'll go in reverse for the cases. Okay. Actually, we'll go on the communication part first. Okay. This is why we love Dr. Sami Khan's DKT teaching. Okay. Because this is where we iron out our exam is not just about knowledge. Exam is also about presentation and showing that knowledge in the right fashion. Okay. And the last case is actually a very good example of it. You obviously know about hypertrophic osteoarthropathy and things like that. But in my limited experience as a musculoskeletal radiologist, I've never seen hypertrophic osteoarthropathy affecting the femur. Okay. So it would be a very, very, very exceptionally rare case. Okay. You kind of like, I felt you were very nervous. And that's okay. This is part and parcel of us doing these vivas because that's where we iron out how to get. I always tell my trainees when I was in UK, I would tell them, exam is a game, right? It is a game. You're going there. I used to go for my vivas mentally preparing not just for like to answer the question, but I would be going in there with like, this is a game. You're going to throw things at me and I'm going to throw them back at you, right? You're going to show me a case and I'm going to hammer that case to the best of my abilities. It's a game. It's a mental game as well, because believe me, we had the worst type of exams where we used to go into the Royal College in the old building. We would be sitting in the dungeon for 1 hour with these other nervous trainees, some of who would be like more nervous than you, and then you go for your exam. So it just adds to that horrible feeling, right? So you have to figure out how to cope with it. And if you can't figure out how to cope with it, you're going to go into the Viva and you're going to start talking and talking and talking, and the examiner is going to be like, this person does not know what they're talking about. Okay. So slow down when you are describing the case. Okay. Slow down. Really control how you're speaking. Speak slowly, speak methodically, speak in a very calm, try and calm yourself down. Okay. That's the only feedback that I would give you. And the second feedback is if you ask a question of an examiner, stop. Don't talk over him. Expect him to answer, because I wanted to answer and then I'm like, she just asked me a question and now she's, like, am I supposed to answer or not? Right? So that's the feedback in terms of the communication part and presentation part. This is actually an Aunt Minnie of a case. This is a type of an insufficiency fracture, but this is the type of insufficient fracture where the bone density is normal. And I tried to give you a hint. I said a 77-year-old female, a female. This is a bisphosphonate fracture. Okay. And the imaging appearances are fairly typical. Okay. So they get these fractures in the proximal, they get it like within 4 or 5 centimeters of the intertrochanteric line. Okay. The fractures, usually the insufficiency fractures usually starts at the lateral margin, which we saw on the other side. Okay. So they'll start there. Okay. And there's literally no specific history of trauma that these patients come in. It's like a minor trauma and then the bone goes. Okay. So this is a very classic appearance, right? The bone density looks pretty normal because they're on bisphosphonate, but it is an insufficiency fracture in reality, right? So this is a bisphosphonate fracture. And the clue, even if you were not sure about that, the clue was in this radiograph. Okay. So yeah, there is periosteal thickening, and there's periosteal thickening in almost the same level as the contralateral side, because this patient has got an insufficiency fracture, which I can show you here. Because if you had done that, then I would have shown you the CT scan, which would have shown you the fracture. Okay. So this is a bisphosphonate insufficiency fracture. Unfortunately, this becomes a clear fail. There's this like a zero, you get a zero on this case, okay? Because you couldn't answer the question right. The second one, again, one of the things that I would say is, and it's so the way I went for my vivas, right? If I was 100% conclusive that this is like, for example, I see a case of rheumatoid. Now I know it's rheumatoid, right? There's no other differential for it except for rheumatoid. So what I would do is I would say it's rheumatoid, and then I would describe the findings with a lot of confidence. And sometimes I would say there's this, and that, right? But in this case, you kind of felt very confident, but your confidence was completely off the chart, right? You were absolutely confident this is a chronic sort of a pathology. This is anything but chronic. There is intramedullary signal change, there is periosteal reaction, there is a scalloping of the bone, but the bone still looks very irregular. So this is anything but a chronic process. It may still be a chronic process, but you cannot completely exclude an acute or a more recent pathology. This patient has come in with 2-month history of slowly progressive swelling, right? Yeah, it could be tenosynovial giant cell tumor tendon sheath, but you have to keep other differentials in mind. You have to keep some sort of a bone tumor in mind. You have to keep some sort of infection in mind as well. You'd never mention infection. You never mention any other thing. This is actually an interesting case because you would look at the frontal view and you think you're dealing with an inchondroma, and then you go on the lateral view and you're not dealing with an inchondroma, and then your mind starts playing games with you. So now you have to think of proper differentials. This periosteal reaction, there is, and it's not exactly a lamellated periosteal reaction. It's actually kind of like almost like a sunburnt, a sun ray sort of a periosteal reaction. So this is an aggressive process that's happening, not a typical for tenosynovial giant cell tumors within sheath, which are fairly indolent sort of tumors. Could be an infection, yes, but this actually turned out to be a metastatic deposit from a lung primary. Okay, this patient had a lung primary, and this was a metastatic deposit. So you went down on the very wrong tangent right from the word go, and then it was like literally no coming back from it. You kept on insisting, this is chronic, this is chronic, this is chronic. This is not chronic. This is actually a more recent, not very acute, but a more recent process that's going on. Okay. So unfortunately, you failed that one too. And the last one actually is an interesting case because it shows not subchondral changes. These are erosions. Okay. These are actually erosions. Okay. And when you start seeing erosions with normal bone density in atypical joints, there are very few differentials that come to your mind. Okay. And then one of them would be gout. Okay. PBNS would be one differential where you can see erosive changes, and the late stages you see loss of joint space. But to get bilateral PBNS would be kind of unusual. So this is actually a case of gout. This is not osteoarthritis. I don't see any osteophytosis. I don't see any other evidence of osteoarthritis. I know it's not a typical location, but that's the whole point. I need you guys to think a little bit differently, right? These are visible on the oblique views as well. That's why I put them up. This is erosion. This is not subchondral cystic changes. This is not typical for subchondral cystic change and osteoarthritis. These are actually erosions. Gout this is gout erosions in a very, and the reason I actually showed you this was because on the first case you said atypical appearances around a joint, possibly gout. So I'm like, okay, this person knows gout. I'm going to bring gout into the picture and see what this person tells me. Okay, but this is not osteoarthritis. Osteoarthritis, you can put it as a differential, but it would not be my primary differential. Primary differential would be some gout or some other erosive pathology. Okay.
Yes,
All
sir.
right. Candidate number 3, please.
Hello?
Yeah, I can hear you. Can you hear me?
Yes.
Okay, all right. So I'm going to show you a very good case. You can take control if you want to. There are 3 images. Tell me what you think.
Okay, control, I don't know from where I can get. No?
I haven't received the request.
I don't know from where. Anyway,
Yeah, please go on.
I am presenting a radiograph of skeletally mature patient of hand, frontal view. I can see narrowing of the shaft of the visualized metacarpal bones associated with the irregular surface of the carpal bone and irregularity in the articular surface of the metacarpal joints and the radio and the ulnar carpal joints. This is the texture of the bone is seen normal. This is maybe one of there is also soft tissue, large soft tissue swelling seen involving diffusely seen around these joints. This is maybe I may think this is maybe edema. This is maybe a soft tissue edema with the underlying joint affection. It's my
Okay.
Stein.
Let me put up another view.
Okay.
Yeah, there you go.
Sorry. This is it looks actually like the edema due to this clearance of the lymph nodes in the patients of breast cancer patients. Also,
Okay.
the other possibility, the filariasis also can give unilateral limb, soft tissue swelling and edema. However, it's more common in leg.
You mean elephant leg?
Elephant leg. But
Yeah.
I didn't see it before in the hand.
No. So when you say filariasis, I'm assuming you mean elephant leg, or
yes.
Yeah. Okay. All right. Okay. That's not what it is, but I'll buy that for now. But that's not what it is. We'll come to that. Okay. Any other differential?
Like lymphatic, also a lymphatic infiltration in post-operative patient breast cancer, and
Okay.
I don't remember the name.
Okay, let's just briefly discuss this before we move on. When you say lymphatic obstruction, right? Would you think that the lymphatic obstruction would affect from the MCP up to the distal forearm and spare the fingers and the proximal forearm? Would that be something that would suggest? I would expect lymphatic obstruction to have a gross swelling of the entire arm. Is that a fair enough comment? It's the entire arm. Okay.
It's more all the limb arm.
Okay, and the second question, and this is me trying to not to like discount what you're saying, but me trying to teach you some things, right?
Yes, sure.
Do you think it's reasonable to say that there is scalloping of the bones in this patient?
Yes, there is scalloping of the bone, and I think may also what causes scalloping in the bone, but more on the distal parts of the hand, there will be scleroderma, and also the skin will be tightness, not edematous. So that's why I didn't like any.
Okay.
I excluded the scleroderma.
Okay. No, that's fine. That's fine. The reason I'm bringing up this part is in a patient with, so I want everybody to understand, when you give the differentials, right, you need to have some sort of a thought process behind the differentials. And our general tendency is, and I'm as guilty of it as anywhere else. When I was preparing for my exam, I went for a few courses, and all the examiners had one thing in common, and they said, please don't speak too much, right? Just speak the relevant things, because I would get nervous and then I would start speaking or giving unnecessary differentials. This is how I learned, and this is what I want to teach you guys. If you have lymphedema from breast cancer, right? You would have to have it for months and years to actually cause this degree of scalloping. Is that correct?
Yes.
That's a lot of scalloping, isn't it? So it's unlikely to have breast cancer causing lymph obstruction, okay, causing just the selective part. Anyway, let's move on. Okay, I'm going to give you another case. Okay, we've done this case, we've done this case. Okay, and let's go for this one. Tell me what you think of this X-ray. So this is, I don't have the age available. There are multiple X-rays. I'm going to show you this frontal view first. If you want, I can show you the others. Tell me what you think. I don't have the age. Sorry for that.
Yes. I'm presenting bilateral hands frontal view radiograph. I can see a marked dislocation and subluxation of all carbophalangeal joints in both hands. This is associated with the normal articular surface, no, not normal articular surface. There is a erosion seen in the articular surface of metacarbopharyngeal joints. Also, there is subsclerotic changes and narrowing of the joints of the carbo-metacarpal and intercarpal joints. This is advanced the first differential diagnosis as it's a proximal small joints affection. It is advanced rheumatoid arthritis. Next step will be review other joints, review the other joints and previous radiographs for other appendicular joints. Also will ask for rheumatoid factor and CRP investigations and rheumatology MDT.
Okay. All right. Okay. Stay with me on this case.
Okay.
So what do you think of this case then? This is the case that we've just reviewed, and this is the case that I've just put up. What do you think of this?
This is another case.
Okay.
This is another case. I found there is dislocation and subarticular also sclerosis. It looks like the same diagnosis, but this one has also a distal interpharyngeal joint affection. This is maybe erosive arthritis.
Okay.
But actually, rheumatoid arthritis also because the proximal joints are also severely affected.
Okay, let's come back to this case. Can you point out where the erosions are?
I am not sure, like if I can take the.
Try and take control if you can. Am I getting a request? No, I'm not getting a request.
From where I can get the request?
It usually is. I'm not sure, to be very honest, because I'm actually. Let me see if I can give you remote control. Candidate 3. Okay, candidate 3. I'm just waiting for you to take screen control.
Okay.
Okay. Have you got it?
Yes.
Okay.
Can you sir see now?
Yeah, it's not moving, but tell me where you see these erosions. I'm interested in seeing the erosions.
Okay. I see this. I think this area. It's the interpharyngeal joints, the metacarpopharyngeal joints, the articular surface of the phalanx, the proximal phalanx is not clearly seen in this this joint.
Okay,
so
we'll come back to this one. We'll come back to this one. Not a problem. I just want to show you one more case before we go on the feedback. Okay. All right. Okay. So this is a patient, okay, who has come in, and this is me telling you exactly the way it happened. This is a patient who's come into the clinic. You're on duty for MSK ultrasound. And this is a patient who's come in, referred by the orthopedic team for an injection into her ankle because she is in pain. Okay. And she's come in with her daughter and she's in a lot of pain. And you are about to inject you're about to do an ultrasound guided injection in her ankle. What do you think?
I can see this is an ankle graph, frontal and lateral view. I can see soft tissue swelling seen in the at the area of the middle malleus. And this is I wanted to I can see also screws down near the
ignore it.
Okay, fine.
Ignore the osteoarthritis at the midfoot. Ignore the screws. Let the soft tissue swelling. is
Oh,
actually subcutaneous lymphedema related to mild heart disease. She's got a history of mild congestive cardiac failure and some chronic venous insufficiency. Ignore all those three.
okay. Can I just make more focusing? I want also to check the joint surface is seen intact. The tibia and the fibio and tibio-talar are seen intact. There is changes seen in the cortex and the medulla of the fibula, distal end of the fibula.
It's perfectly
there is
fine. Mild sort of
fine.
osteopenia, nothing, not Paget's, nothing to worry about.
Okay. There is maybe there is a stress fracture seen in the calcaneus body
Nope.
as line. No,
Nope.
this line
Nope.
of sclerosis is not.
If you're talking
fractured.
about this line of sclerosis, that's
Oh,
just
yeah.
the sustentaculum tali of the.
Okay,
That's
fine.
just the sustentaculum tali.
Okay.
There's no coalition either, by the way. So
Okay. Then
she's in a lot of pain. She's actually literally, her daughter had to. She's come in. She's not able to bear weight actually on her foot. She's in that much pain, and her daughter had to bring her in a
there is
wheelchair from the
actually
parking lot.
healing. There is, I'm not sure, but there is a vealing in in the cortex of the navicular bone,
Navicular
and
is fine.
it's fine.
Yep.
Mm,
Patient is 63-year-old female.
63.
Female.
Mm,
Anything else? You don't have much time, so.
The thing is, like, I can't actually see. I can't see a definite pathology.
Okay. All right. Okay. Have you looked at the bones properly? We say we look at the bones properly, but we honestly don't look at the bones properly. We sometimes miss important things. And I've given you the history, which is very helpful. Have you looked at the bones
Yes, I
properly?
can see actually also the tibia, the tibial surface in the tibiofibular joint is seen ill-defined. The
No,
cortex
it's
is
just
ill-defined.
projectional and a bit of osteopenia. No.
The bone.
Okay. All right. Let me point out to you.
So you
Okay.
can see.
Let's start
Okay.
off here, shall we? Okay, we'll do it together.
Okay.
Okay.
Mhm.
You're going there. You can see the cortex. 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 What's going on here?
Oh, there is a periosteal reaction
Okay.
seen.
All right.
Periosteal
Let's go on to the
reaction
lateral
seen.
view. See the cortex. See the cortex. And then what do you see here?
There is a periosteal reaction of
Okay.
the.
All right. Okay. We're going to stop there because otherwise you're not going to be able to get the feedback. Okay. So this is actually a genuine case. I'm not kidding. This is a patient of mine that actually turned up in my clinic, had an X-ray done, which was not reviewed properly. I'm not saying it's the easiest X-ray to be done, but it is there. So she came in, she was in a lot of pain. She was literally not able to bear weight. And I looked at her and I said, this does not feel right. Looked at the X-ray and I was worried about something else. So what's the next thing I did? I literally took her around, begged and
MRI.
pleaded and tried to get the radiographers to do an urgent MRI right then and there. What is the finding?
Stress fracture.
Correct. Okay. So this is a stress fracture. Okay. She's 63 female. She's in a lot of pain. Okay. There is periosteal reaction there. This was a stress fracture. Okay. And she was immediately sent to A&E. Obviously, they're not going to do anything surgical. She just needs a boot, a plaster or something to immobilize her foot. But this is a stress fracture. Okay. So again, just we say we look at the bones, but we really don't look at the bones. When you're talking about looking at the bones, you must look at the periosteal reaction, which you can clearly see here. Okay. So it's a stress fracture. The second case actually is I kind of showed you Aunt Minnie's. So, all right. Okay. Yes. So this is This is, what is the diagnosis? I'm going to look at the chat. Has somebody put the diagnosis there? What's the diagnosis for this case? Well done to Angam Saleh. Neurofibromatosis. Okay. This is an Aunt Mini. Okay. If you've never seen it before, see it now and just memorize it and make sure that you never forget it. Okay. I have seen only one case when I was doing Viva, and this is the only case that I've got in my collection. Okay, this is a classic Aunt Mini. A lot of soft tissue swelling, gracile bones with a lot of scalloping because this soft tissue has been there for a very, very long time, and it's affecting the density of the bone as well as causing scalloping of the bone. Okay, this is an Aunt Mini. This is neurofibromatosis. Okay, and this is a large, big, giant plexiform neurofibroma in this patient. Okay, look at the soft tissue here. Look at the soft tissue there. There's nothing going on there, but this is completely abnormal. This is not me. This is not nothing else. All right. The second case is actually also kind of like an Aunt Mini. Okay. Now you actually told. I think people look at this and they start thinking this is erosions. This is not. This is Jacob's arthropathy or SLE. Okay.
Systemic lupus.
Yeah. So this is the reason why I actually put this case right next to it. Okay. This is what rheumatoid arthritis is. Okay. Yeah. They both have ulnar subluxation. This one also, but look at the metacarpal heads here. Okay. Irregular.
This
erosions.
reversible soft tissue swelling.
Yeah. This is all.
Subluxation.
Yeah. This is all. There's no erosions there. There's literally no erosions that I can see. And the reason you're getting this changes here is because this is a disease which affects the ligaments, which is why you're getting this ulnar subluxation. So this patient has got scapholunate dissociation, okay, widening of the scapholunate articulation. And now the capitate basically has started to come down, causing osteoarthritis. So this is slack wrists which are developing. Okay, so this is Jacob's arthropathy. It's pretty classical. Okay, it is not erosions. Okay, just subluxations. All right. Okay, that's you done. Okay, last candidate, please.
But you didn't give me a mark, doctor.
Well, okay. So obviously you can't pass the Jacob's arthropathy, and you can't pass, like, they're kind of like you describe the findings. So I think in both those cases, you're gonna for neurofibromatosis you're gonna get borderline fail. For Jacob's arthropathy, it certainly is going to be a fail. And again, for the last case, which I think was the periosteal reaction, again is going to be borderline fail to fail because you didn't manage to pick up the findings. Okay, so in terms of communication, what I would say is just again slow down. This is the most important thing that we have to do when we are sitting FRCR. Slow down, right? Just calm, collected. Speak methodically, logically. Slowly. Give reasonable differentials. If you don't know the differentials, right? And I understand, right? Because obviously, I mean, looking at your Viva, it was clear that you had not seen a case of neurofibromatosis before, right? If you don't know the differentials, right? My advice to the trainees is maybe spend a little bit more time describing it. What that does two things. Number one, it actually there's information at the back of your brain sometimes, right? You know something, but you can't put your finger on it. You don't know how to say it, right? And by describing it, right, the bell at the back of your head starts ringing, right? And then it's just like, oh yeah, that's what it is. That's what it is, right? And then you start saying. But the second other important reason is that you literally are trying to buy a little bit time with the examiner, okay? And your brain is like in the background, it's like running at a speed of knots to try and figure out. And what that will sometimes do is it will actually help you from giving the very wrong differentials. Obviously, I can see where you're coming from in terms of lymphedema related to previous breast surgery and things like that. But then when you're talking about it, you're describing and you're saying, oh, there's soft tissue swelling there, and your mind is telling you, there's probably previous surgery and that's why there's lymphedema. But then your brain in the background is saying, hang on, it's localized from the metacarpals up to the mid forearm. The proximal and the distal parts, the soft tissues look completely normal. So it can't be subcutaneous lymphedema related to surgery. Go find something else, right? So you don't have to rush in from the very first 5 seconds to this is the differential. Take your time, describe it. If you don't know, it's a balance. If I show you, and this is an example for all of us to learn from. If I show you this case, right? Okay, I'm showing you this case. You know this is rheumatoid arthritis. What you don't want to do is sit for 5 minutes and waste 5 minutes of your time describing rheumatoid arthritis. You should literally start off by saying there are erosions at the carpus, metacarpal joints, interphalangeal joints with ulnar subluxation, osteopenia, penicillin cup deformity. These imaging appearances are most consistent with rheumatoid arthritis. I would like to have previous imaging to compare whether there's any progression of the disease. Patient needs to be referred to rheumatology, MDT, if the patient is not already under the care of the rheumatologist, blah, 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 right? 30 seconds, 1 minute, right? But you know the diagnosis. But in cases where you don't know the diagnosis, describe. Let the differential come to your brain if it's there. But in the case that you have not seen like a neurofibromatosis, even if you don't know the answer, you may be able to give some sort of a reasonable answer that the examiner is like, okay, fine, they didn't know the answer, but they give it a very good shot, and that puts you in good stead. Okay?
Okay.
All right, candidate number 4.
Hello, sir. Good evening. I'm
Good
candidate
evening.
4.
Okay, candidate 4. All right. Okay. Let's start off with this case. And I'm going to show you both the images. Okay.
I've been presented with frontal and oblique projections of a skeletally immature patient of the right lower limb, where I can see there's the visible deformity. There's deformity involving the shaft of the right femur. Besides that deformity, I can clearly appreciate a transverse fracture with sclerotic borders around and surrounding callus formation along the proximal diaphysis. In the other oblique radiograph, I can also appreciate some dense metaphyseal bands in the distal femoral distal metaphyseal regions. I cannot appreciate any other abnormality. To me, the bone density in this particular radiograph appears to be slightly reduced. Now, however, I would confirm this finding by comparing it with the other radiographs of the patient as well, if available. So if the patient is, I'll correlate my findings with any given history. If the patient is having a known bone disease, my top differential would be osteogenesis imperfecta with presenting with fracture. In that case, I would be evaluating rest of the bones as well, because the patient might be having other fractures as well. My for I'll also I cannot appreciate any epiphyseal changes. So yes, osteogenesis imperfecta. I cannot appreciate any background abnormality within the bone to within the medullary or medullary region to give a diagnosis of any pathological fracture.
Okay, here's a question for you. These dense metaphyseal bands, what could they be related to?
So these can be normally they can be a normal physiological finding as well. However, if the patient is on therapy for his underlying disease process, these can appear because of that. In rickets also, we can see dense metaphyseal bands. But in this patient, if the patient has a known diagnosis of osteogenesis imperfecta presenting with this deforming bending of the bone femur with fracture and these dense metaphyseal bands, it can be because of underlying ongoing therapy for his disease process.
Okay, all right. We are going to move on to the next case. Okay, can you take control of the screens because you may have to scroll?
So unfortunately, I'm unable to find the option. It's not coming beside your name. Usually
Okay,
it does.
hold on.
I'm sorry.
No, don't worry. I'm just trying to give you the control. There you go. Okay. No, hold on. You've got the
Oh,
wrong button.
sorry.
Hold on.
Sorry.
No. Don't apologize. Nothing to apologize for. I would use the arrow keys for scrolling. Okay. So this is a 62-year-old patient who's come in with back pain. There are scout images and three. There's sagittal T2, sagittal T1, and axial T2. Hold on. I think you
Sir,
need to
let me the arrow
don't use the
keys.
mouse. Don't use the
Okay,
mouse. Use the arrow
I'm
keys.
sorry.
No, don't worry. Don't worry. If you want to use the mouse, you can use the mouse now because I've changed
But
the
I guess
setting.
that's the mouse is not scrolling it. I'm trying to scroll it with the keys.
Okay.
Is it me or is it you?
Have you still got control? Can you move the mouse? Yeah, you still got control because you're moving it. Okay. Do you have a scroll wheel on your mouse? Try that.
Sir, I'm on the laptop and I'm trying with the arrow keys. It's enlarging and minimizing, but
okay, then try the other two arrow keys.
no, this changes the.
Okay, you should be able to use the scroll mouse then to. There we go.
Yeah.
Oh, you just yeah, that's fine.
Is it me or is it you? Is
no,
it me?
You're scrolling.
Yeah.
You're scrolling.
Okay.
Yeah.
Okay. Thank you so much. Thank you so much.
Hold on. Yeah, go on, please.
I'm sorry, I'm still struggling. I'm trying to adjust. I'm not sure. Why is it giving?
All right. Okay, let's take away this case then. Okay.
I'm so sorry.
No. Don't worry about it. Don't worry about it. We'll get you a good case. Don't worry about it. Okay. All right. So this is a. Let me just reset it and scale to fit. Okay. What do you think of this one? Hip pain.
So I've been presented with a frontal radiograph of a pelvis of a skeletally mature patient. In the first instance, I can see there are multiple lytic areas involving the pubic rami bilaterally. Also, I can see some lytic areas involving the left femoral shaft, neck, and head. Bilaterally hip joints otherwise unremarkable. I cannot appreciate any gross abnormality in the iliac crusts or the iliac wings. I cannot appreciate any fracture line. The visible vertebrae, transverse processes, and the visualized part of the sacrum appear unremarkable. So coming back to the findings, these are multifocal lytic, small-sized lytic lesions involving the said regions. If the patient is of older age, my top differential in with these deposits would be metastasis if there is a known malignancy, since these are lytic. So I would evaluate the patient for breast if it's a female, or it can be from the lungs, kidneys, or thyroid. However, besides the metastasis, I would also keep myeloma is in my differential. For that, I would like to check if the patient has undergone any screening for that. I'll immediately inform the findings to the referring physician, and the patient needs to have a screening for multiple myeloma, including.
Okay, can I stop you? Can I stop you?
Sure. Sorry. Yeah.
Okay. All right. Number one, can you point out where you see the lytic lesions in the pubic bones?
Now, are you able to see my arrow?
No, I can see it moving. Yeah.
You can see now?
Yeah. These are just projectionals.
All of these?
Yep. These are just projectional. Okay.
And
what about
all
any other
these?
Yep, just projectional. Any other
These
areas?
are all projectional.
Yep, these are all just technical.
Okay, let me get back
Okay,
to
let me tell you something. Let me tell you something more importantly. Patient is only 29 years old.
Okay. I'm reviewing my findings again.
Yes, please do.
Thank you. Okay. 20-year-old.
29. Okay.
29-year-old.
Yeah, 29-year-old.
Okay. I can appreciate patient has undergone some contrast study where I can see the contrast and the distal ureters. If
Ignore
that's
it
relevant
completely.
to my, sorry?
No, ignore it.
No,
ignore it.
Okay,
it.
okay. Okay. 29-year-old, for the sacroiliac joints.
Completely normal.
Medial medialization.
Can
So,
other candidates please mute themselves, if you don't mind? Thank you. Yeah, go on, please. Candidate number 4.
Thank you. So, there's some faint ossification along the, I can appreciate, I'm not sure if it's projectional again, on the lateral aspect of, on the right side, along the gluteal muscle.
Okay, I'll give you a hint. Patient is complaining of left hip pain.
So on the left side, I'm looking at the bones first. The iliac bones appear normal. Femoral head is well shaped, non-sclerotic, non-flattened. The acetabulum appears fine, with some areas of overgrowth, likely early osteophytes along the superior margins. Lesser and greater trochanter's on the left side appear normal. Medullary cavity of the femur appear normal.
Okay, all right. Okay, let me take control. Okay, right hip, right femoral head. Any abnormality? Any bone density changes? Anything going on there?
The acetabulum margins are very subjectively sclerotic.
Which side? Right side is normal. Right side is
right
normal.
side, then the left side is also okay. If the right side is normal.
Look at the right femoral head. Everything good? Now look at the left femoral head. Does that look good? Look at the right acetabulum. Look at the left acetabulum. Look at the bone density here. Okay?
Yeah.
And look at the bone density there.
Right, sir.
Okay. All right. Okay, we'll come back to this case. Don't worry about it.
Yeah.
We will come back to this case. Okay. All right. We have done that. Okay. All right. Let's show you. Because you can't scroll, I am kind of limited. Okay, but this is a good case. Hopefully you. No, don't worry about it. Don't worry about it. We still have good cases. So we have to stick with plain films. Go on.
Is it the same patient, sir? Oh,
No,
okay.
it's a different patient.
Okay, yeah. So, lateral skull radiograph of a skeletally mature patient. I can appreciate multiple variable-sized lytic lesions diffusely spread across the calvarium with some sparing of the occipital region. I cannot appreciate any significant calvarial destruction in this. No soft tissue or scalp swelling. The upper cervical spinal vertebrae have some osteopenic changes. However, I cannot appreciate any significant pathological fracture. Rest of can I please know the age of the patient?
55 years old.
So, right. The posterior occipital area has also got some focal area of lucency in a rather well-defined fashion.
Ignore that.
So, okay. So the only finding that I can see in this, these are these multiple variable size lytic lesions diffusely spread across the calvarium without any associated soft tissue. So keeping in view the age of the patient, my differentials would be METs versus myeloma. Since the density of the cervical vertebrae on this particular radiograph is also somewhat osteopenic, so I'll consider a multiple myeloma as well, and would like to screen the patient for myeloma as well as METs. And
how would you screen the patient with? How would you screen the patient for myeloma? What are the guidelines these days for UK for screening patients with multiple myeloma? And what
so
other From
If we
imaging
want
perspective
to,
and non-imaging perspective, I want to know both.
okay, for non-imaging side, we can do the Benz-Jones proteins and serum electrophoresis, while for imaging purposes, we can do a low dose whole body CT or MRI.
Okay, all right. Any other differential for this case?
And also,
Could this be, okay, here's my question to you then. Could this be hyperparathyroidism?
exactly, I'm thinking on the lines of hyperparathyroidism as well, because it can also give multiple lytic raindrop kind of appearance. And if the
But
patient has got a known history of chronic renal failure, that would be my top differential as well for this pepper pot appearance.
okay, all right. We will come back to this case. Okay. Okay, let's look at this one. And default. Yeah. So patient with left hip pain. Actually, I'll just leave it at default. Yeah. Patient with left hip pain.
X-ray frontal projection of a skeletally mature patient, X-ray pelvis of a skeletally mature patient, where I can see a displaced and avulsed left ischial tuberosity, which is giving an irregular sclerotic margins. There's also the parent bone of the left side also appears irregular. Besides that, I'm looking at rest of the bones. There's also an ossification along the medial aspect of the right femoral neck, and I would like to. It is within the soft tissues.
Can you point it out?
Can you see my? Oops.
Yeah.
This one.
That's the vascular.
Okay, so the prime pathology that I can see, I cannot appreciate the sacrum appropriately in this windowing, and if
Sacrum is fine.
Yeah, with windowing we can have a look. Otherwise, if it's fine, I cannot appreciate any other abnormality. So this if the patient has been having a pain for a pretty long period of time, this may represent a neglected avulsion fracture of ischial tuberosity on the left side. Because there's also irregularity of the ischial tuberosity itself, so that would be my top differential. Otherwise, for the calcification overlying a soft tissue with this configuration, also myositis ossificans would also be in my differential list if there is a history of trauma. And these findings need to be communicated to the referring physician. Patient can be further evaluated with a CT for confirmation of the finding, and orthopedic referral or fracture clinic can further be informed about this patient.
Okay. Anything else? Before we move on to, you may have time for another case. Anything else?
So the femoral necks, femoral shafts appear normal. I'm not very happy with the windowing of the femoral heads, so I cannot comment on the sclerosis that is visible over here.
I think femoral heads are absolutely fine, but I've
Yeah.
windowed it a little bit if
Okay.
that makes a difference.
Sacrum, lesser trochanters are fine, greater trochanters are fine, femoral necks. I cannot see any asymmetrical cortical thickening along the medial or lateral aspect of the femurs bilaterally. Yeah, the trochanters, greater trochanters are fine. Iliac bones, iliac crust and wings, as seen in this window, appear unremarkable. I cannot clearly see the sacroiliac joints, unfortunately. And
Fine. Sacroiliac joints are fine. Okay, I'm going to show you one more case because I want you to make the most of this. Okay. And then what I'll do is just for everybody in the group, I'm going to put up a case. Okay. And whoever gives the answer first gets his name called out on the session. Okay. But once we're done with the Viva. Just one case. Just one case. Okay. Go on, please.
I've been presented with a frontal radiograph of abdomen, including including the lumbar and lower dorsal vertebrae and the pelvis. The first thing that I can see is a patchy sclerosis and mild deformity of the right femoral head as compared to the left side. Also, the the lumbar vertebrae have somewhat depressed superior and inferior end plates, giving an appearance of H-shaped vertebrae. Sacroiliac joints, iliac crusts appear normal. Pubic bones bilaterally appear normal. Trochanters appear normal. So I would like to correlate my findings with there's some sclerosis apparently of the ribs as well, but I would definitely check other radiographs to confirm my finding, because there's patchy density of the visualized vertebrae as well. So I would like to know if there is a diffusely increased bone density of the vertebral body and the ribs, or if that is just projectional for the ribs. Because for the pelvis, the density appears to be normal, except the femoral head I've described. The bowel patterns that I can see
It's
is
completely normal.
no, yeah, it's non-specific and normal. I cannot appreciate any radio dense region in the right upper quadrant or the flanks. The pedicles are visible. The spinous processes are fine. Transverse processes. I cannot appreciate the transverse process of the L4 right, but that can be because of the overlying. That can be because of rest. I cannot appreciate any other abnormalities. So I would like to the differentials on the findings of this patchy sclerosis of the right femoral head. I would like to know the history of the patient. If the patient is young and having a right-sided hip pain, this can be early stage of right femoral AVN, where I cannot appreciate significant osteoarthritis at the moment, but some patchy sclerosis and lucencies are there. And the presence of H-shaped vertebrae in this projection with these findings makes me think of sickle cell disease. However, I would correlate my findings if there is any prior imaging available, or if there is any prior history of any hemoglobinopathy.
Okay, we're going to stop there, okay? Because I'm going to lose my train of thought, what I want to say, okay? So we'll go in reverse, all right?
Yes, sir.
Now, you got this case, it's sickle cell disease. You got it. I think sometimes we are too obsessed with giving a management plan. We are too obsessed with giving, like, we have to say something. No, you don't have to, right? You don't have to. You can just say the overall imaging appearances are consistent with sickle cell disease. I would let the clinical team know that at this point in time, I can't see any sort of collapse of the femoral head, right? And so in this kind of case, you've picked up the most important findings, right? You've picked up that there's H-shaped vertebrae, there's avascular necrosis. You've added 1 and 1 plus 2 together to give the diagnosis of sickle cell disease. You can give the relevant negatives in this case. What would be the negative relevant, bearing in mind this patient has got an abdominal X-ray? So we've done it obviously for abdominal.
I could not appreciate splenomegaly, so I would check if there is any history of splenectomy, or it can be autosplenectomy as well.
Okay.
Or there is definitely no AVN, definitive AVN on the left side.
Can I finish?
Sorry. Yes.
No, it's fine. Okay. Autosplenectomy is calcified spleen.
Yeah.
Okay. So not splenomegaly. You're right. You're looking for autosplenectomy. So there's no calcified spleen. That's one negative pertinent differential. The other pertinent negative differential is no gallstones. Okay. So you can give these negative differentials, right? There's no evidence of bowel ischemia. Sickle cell disease is a coagulopathy. Okay. There's no evidence of bowel ischemia. Bowel gas pattern is non-specific. These are the relevant differentials that you can give. You all must learn how to close the case. You guys are struggling, right? You don't know how to close the case. It's a trick that you have to learn. And not every case has to be given like I have to go to refer this and I'm going to refer that and I'm going to refer this. A lot of these patients are actually, you can just say, I can't see any evidence of bowel obstruction. I don't see any gallstones. I don't see any autosplenectomy in terms of calcification of the spleen. I'll let the clinical team know. at this stage, all I can see is chronic changes of sickle cell disease, and let it be. Okay, and there's no collapse of the femoral head. Not every case has to be given a certain, what is the management of these patients? They're going to be treated conservatively. Nobody's going to go and operate on them. They're going to be rehydrated, and they're going to be just treated with pain relief. Okay, so yeah, just be mindful of that. Learn to see where the case ends. This is unfortunately a clear fail. And this is a difficult case for me to define. I was reflecting on how to evaluate you, right? Because you picked up the myositis ossificans, and we'll come to that. But what you haven't picked up is this patient has got a big, large lytic bone lesion with soft tissue mass hiding in there. And I apologize for saying this, but you can't argue that the windowing is not appropriate. It's got nothing to do with windowing. I'm going to put it on auto windows. And even then, you can clearly see the margin, the iliopectineal line on the left side. It's disrupted. There is no iliopectineal line. And this is one of the areas where I was actually told to look when thank God for Nigel Raby. I don't know whether anybody knows his name. He's actually retired a long time ago. He was the very first MSK radiologist I encountered. And one of the very first cases he actually showed me was an iliopectineal line disruption for a fracture. So as a musculoskeletal radiologist, it's drilled into my head that when I look at the pelvis, I always look at the iliopectineal line to see if there's anything going on there. This is a metastatic deposit. This is bowel gas, but this is a metastatic deposit until proven otherwise, okay? Second thing was you mentioned displaced avulsion fracture. Okay, it can't be an avulsion fracture of the iliac bone if the iliac bone is still there, okay? Avulsion fracture means a bone fragment has sheared off. If there's a big giant bone fragment there, this is myositis ossificans, okay? You're not going to do anything about myositis ossificans. You're not going to do a CT. You're not going to do an MR. You're just going to tell the clinician, red herring, mate, myositis ossificans. If you want to take it out, take it out. If you think it's symptomatic, doesn't need any further imaging, okay? This is the most important finding here. Everybody looks at that. People then forget to look at the whole pelvis, okay? So unfortunately, this is a fail, okay? Sorry, there's no other way I can grade it. And this is a significant fail as well, because obviously it's a malignancy. So it's something that the examiners are not really going to be looking favorably. You picked up this case, okay? And you kind of, the reason I actually asked, the two things here. The reason I actually asked whether this could be hyperparathyroidism is because it's less likely to be hyperparathyroidism. Typically, hyperparathyroidism, you get multiple lucencies, but these are all pretty much the same size. This is sometimes described as a raindrop skull. Why they say raindrop skull is because there are lucencies which are there, but they are like some tiny, some bigger, some even bigger. Okay, so they are of variant sizes. This like water splashing on the floor, right? Maybe one drop, but once it splashes, it doesn't mean that they're going to be uniform size. Okay, so this is a raindrop skull, but you were otherwise absolutely right. METS myeloma would probably be a bigger differential than METS, but the two differentials were right. In terms of screening, I've never heard of low-dose CT for screening. MRI is definitely the recommended imaging modality of choice. So just be aware of what you're recommending, okay? I mean, I don't think the examiners are going to mark you down for that, but CT is not the imaging modality, it's the MRI scan. And obviously you can look for light immunoglobulins and, Bence-Jones proteins and things like that. Okay, next case. Unfortunately, this was also a fail. Okay, so the abnormality is actually here. This is normal bone density. This is not normal bone density. There's an erosion going on here. There is scalloping of the bone here, okay? But at the same time, there are erosions at the joint, but the joint margins, the joint space is preserved. So what is it?
So pigmented villonodular synovitis?
Correct. This is PVNS, okay? This is PVNS. All right, so you can clearly see the same findings, okay, involving the femoral head and the acetabulum, okay? This is PVNS, okay? So if you see erosions at the joint with preservation of the joint surfaces till the end, eventually it will collapse, but that occurs very late in the disease, so that is PVNS. Okay, the last case, this one you nailed it. This one, like excellent pass. Okay, you knew all the answers. This is pseudoarthrosis, gracile bones with reduced bone density, osteogenesis imperfecta. Pretty much aren't many these striped lines or dense metaphyseal bands related to bisphosphonate therapy. Okay, no issues here. You get the highest maximum mark that you can get for this one. Okay, overall in terms of your communication skills, presentation, I think you're pretty decent. Again, just same advice as everybody else. Just slow down, just control your breathing, control. It's very easy for me to sit here and say this. I understand. I'm not trying to judge you. I'm just trying to give you advice. Just slow down, because sometimes when you're going with a very fast train of thought, you kind of lose sight of the examiner trying to help you. You kind of lose sight of the examiner trying. And examiners are human beings, right? If they're sitting on the chair hour after hour going through different trainees, if a good trainee comes along, they'll be interested. If a trainee that's not quite good, they might slump in the chairs. We are all human beings. That's why there's so much effort to remove any sort of bias or any sort of that sort of a element creeping in. But you can help your cause by just slowing down a little bit, speaking a little bit slowly, taking your time, and just going through the cases in the right manner. I'm going to put a case here at the end. Okay, and this is just for fun. Okay, I don't know whether I have the case. I have the case. Hold on, let me just put there. Okay, if you don't get the answer, don't worry about it. Okay, if you get the answer, brilliant. I want to see who gets it first. Okay, spot the abnormality. Oh, sorry, let me just put that there. Okay, spot the abnormality. Just for fun. Dr. Imran Ladakh, you don't count in this session. I think everybody picked up on Dr. Imran Ladakh's answer. I know Dr. Imran Ladakh, so yeah. Okay, has everybody seen it? No, it's not a cuboid lytic lesion. This is a rare case of an absent medial sesamoid. Okay, absent medial sesamoid. I have never seen it before. I just find it very interesting. This is congenital. It's an incidental finding in this patient. Okay. All right. Any questions? Anything? You guys are, the forum is open. If you guys have any questions, I'm happy to answer.
Sir, can I please ask a question?
Of course.
It's regarding, there are two actually questions. One regarding the skull lytic lesions. In that case, if we are having such case in Viva, of course, we can tell them what is our thought process. But if such case comes in the shorts, what should be our top differential? Because our management would depend on that. So what should be our top differential versus differentials then? Top diagnosis versus differential then.
Okay, when you say short, you mean, I don't know what you mean by short. You mean
so
like...
Actually, they have changed the system from June 25,
Okay.
and now we are presented with 25 pathological x-rays instead of rapids.
Okay.
And
And what are you supposed to write?
We are supposed to give the description, all the findings, diagnosis, differential diagnosis, and management according to our diagnosis. So if we don't get the diagnosis right, we are going to mess up the management in any case.
Okay, so I don't think that so in that kind of case, I mean, it would be wrong of me to actually give you a definite answer for this. Okay, so the way I would approach it is I would put myeloma as a top differential rather than METs. Okay, because of the significant number of lucencies that you see. So myeloma would probably be my top differential. Okay, not METs. If you are, the question is if they're asking for one differential or multiple differentials. Okay, if they're asking for multiple differentials, then myeloma, METs, and then hyperparathyroidism would probably be the top three differentials. Okay, and in terms of management plan, so again, I would just write if known history of, unless if you would assume that the patient doesn't, they're saying that the patient does not have history of myeloma or METs or not known, you would say, okay, whole body MRI scan to confirm, to visualize the extent of disease. And for metastatic disease, you can say unless there's a known primary, or you would still recommend a CT chest abdo-pelvis to determine the extent of disease and to find a primary site. That's the way I would word it. But myeloma would be the top differential,
Right,
followed
sir.
by METs and followed by hyperparathyroidism.
All right. Thank you so much.
Okay. Any other questions? The feedback link, you have to sign up and register with Dr. Samila Khan's website, Dr. Khan's
Doctor,
teaching.
Excuse me,
I want.
Oh,
excuse me, I am going to paste it in the chat now.
oh,
Thank you.
brilliant. Thank you very much, Dr. Samila Khan. Okay,
Excuse me,
so
Doctor, can I ask a question?
of course.
In my cases, you said I have to differentiate between the erosions and the Jacquard arthropathy. Could you show
Yes.
me that part? Like, I mean, how to differentiate between both?
Okay, so the thing is that obviously this is the case that I showed you, Jacquard arthropathy. Okay, so it's difficult because you don't really see the joints very, very well. But if you look at the metacarpal head here, it's not eroded. This metacarpal head here is not eroded. The metacarpal head here is not eroded. The metacarpal head here is also not eroded. You can't really call this erosion because you are not seeing the bone margins very well, but more importantly, what you're seeing is literally the base of the proximal phalanx on FAS. Okay, so this is actually you looking at the bone from the bottom. So to call it erosion would be a mistake. Okay, and again here, I am not convinced that these are erosions. Okay, this is all osteoarthritis. Okay, this is scapholunate
I mean the
dissociation.
intercarpal joints.
You mean these
area
joints
this.
here?
So
These are not erosions. Compare this to this case here. No, sorry, not this one. This one. Okay, look at the margins here. Erosions, all these irregular. Okay, look at the margins here. Look at the pencil and cup deformity. Look at the loss of articular surfaces here. These are all very much consistent with erosions. So this would be rheumatoid, okay? Whereas the earlier case, this would be Jacquard's arthropathy, okay? There's nothing going on in terms of the erosions. There's no erosions there. This is just osteoarthritis. And I think this is what confuses the people, but this is what the point is in Jacquard's arthropathy. You get ligamentous insufficiency. So your scapholunate joint is now affected.
Okay.
Any other questions?
No, thank you so much.
Okay, all right. If there are no other questions,
There is in the case of the MRI, the first one, lymphoma, there is a
yes,
soft tissue intraspinal canal, right?
yes.
This also considered part of the.
Yeah, so lymphoma typically has like, so if you see a lot of soft tissue mass around it's difficult because I don't have an example to show you. So bone tumors, lymphomas, osteosarcomas, and Ewings, so particularly Ewings. Ewings will show a lot of adjacent soft tissue mass around it as well, but the infiltrative mass is more typical of a lymphoma. Okay, and this case actually the clue is not just the soft tissue mass. The clue is actually the significant volume of lymphadenopathy that you're seeing both in the mediastinum and in the presacral region. Just a recap, okay? So this is what lymphoma soft tissue disease would look like, okay? But look at the lymph nodes here. These are all lymph nodes. These are all lymph nodes here, and these are all lymph nodes in the presacral region as well. So these are all lymph nodes. There's a nodal disease going around here. All these are areas that we have to review when we are reporting lumbar spines. So this is nodal disease. So this would be consistent with lymphoma. TB can be a differential, I would argue, but not the top differential, especially in mind that, you know, there's so much multifocal disease and there's like extra osseous soft tissue, almost like TB is more like necrotic disease. I'm not sure about leukemia being a differential, and I'm a firm believer that you should stick to differentials I like giving differentials which are a bit more to the picture and to the point. Could it be leukemia? I've never seen a leukemia of the spine effect like that. And based on my experience, I wouldn't put leukemia as a top differential.
Mhm.
X-ray of the ankle with stress fracture. Okay, I'm just going to show that so that everybody can have a look. Okay, so this is the ankle. Okay, there is periosteal reaction. I think one of the tips that I would give is make sure that whatever software that I think they've switched to a new software. If you have the ability to zoom, please make sure that you are well versed with the software, right? It's not just about the knowledge. What you want to do. I gave my Royal College of Radiology exam for Canada just this year, actually, in March. And one of the mistakes that I kind of made was I was not aware of the capabilities of the software. And it's even a more horrific exam than the Royal College of Radiology exams in UK. At least I found it to be a little bit more challenging, not because of the cases were difficult, but because you have a very limited set number of times, and literally the examiners are pushing you to you. So it's like there's no discussion, right? And I was not aware of the capabilities of the software. So I was literally struggling. I don't know how I passed. I mean, passed it, alhamdulillah, but I was literally thinking like, oh my God, I'm going to fail. And one of the things that I realized was that I was not well versed with the software. So before you go for the exam, if you're sitting the exam, right, make sure you go on the Royal College of Radiology website and look at the case. So this is the case where the periosteal reaction is right there. Okay. If you can zoom up. Okay. If you are allowed to zoom up. Okay. There's a periosteal reaction there. There's a periosteal reaction here as well. Okay. So this was a stress fracture that was picked up. Any other questions? Lateral tibial cortex. No, I think that's just projectional. Lymphangioma, no. It's a pretty much of an aunt mini case. I would not put lymphangioma as a rheumatoid arthritis in the foot, probably because it's a very atypical location for rheumatoid arthritis. And the bone density is also normal. That's fine. That's fibula. Fibula is fine. I think I'm going to end up answering questions till 4 p.m. If there are no other case related questions or exam related questions, then I think that's pretty much it. Thank you very much for attending the session, and please do put your feedback in, because it really does give us the necessary impetus to improve. I think that's very, very important. We are not just here to teach, but we are also here because of our own learning and how we can become better teachers, and hopefully one day maybe emulate a little bit like Dr. Samiullah Khan, who's mashallah 100,000 times better than all of us combined, to be very honest. But thank you very much for coming, and I hope that session was of benefit for you. Hopefully I may do some sessions in the next year or so, depending upon time and availability. Thank you very much for your time, and thank you very much, Dr. Samir Khan, for organizing this. Really appreciate that.
Thank you very much for absolutely brilliant session. I enjoyed it a lot. And I warn you, every 3 months you are going to be on this forum next year. This should be your new year pledge. Every 3 months on DKT.
Honestly, I would love to. The only problem is that the time clash is very difficult. In UK, it was very easy. Right,
Yeah.
right now it's like 1:30 to 3:30, and I will try and organize it. Sometimes we get academic days, so hopefully if I have an academic day, the problem is I don't get to know my academic days like 10 days before in advance. So I knew that I had leave coming up this time, so I was like, no, I have to contribute, otherwise I'll feel guilty that I haven't done anything for Dr. Sami. So I kind of like, if I have, my next leave is going to be in Ramadan time, so that's completely not possible. But inshallah, maybe sometime in April, March, or something like that, I will definitely do another session, hopefully. Inshallah.
Thank you very much.
No problem. Thank you very much, sir, for organizing this. Thank you very much for everyone to come. Thank you.
And for the audience, next session, 11th is Dr. Priya Suresh. You know that she is a very renowned educationalist. She is also the president of the British Skeletal Society. She was also a Royal College medical director. Her tenure just ended in September. Very passionate teacher. So she's coming on 11th. I think 11th is the next session. So just wait for that. And I think after 11th, we will take a break. We will take a break, and then I think the next session is going to be on 8th of January, or whenever the Thursday is. I think it is 8th, if I'm not wrong. So thank you. And those of you, I think some of you are having, we are having a meeting for the October exam candidates. So tomorrow at 16:30 GMT, you will be emailed the link, and we will admit case, attendees correlating with their names. So please log in according to your names. So we'll meet the October candidates tomorrow at 16:30. I think 60 plus of you have registered. So let's see how many of you come. Okay then. Thank you very much.
Thank you very much, sir. Thank you.